We all get days when our hands and minds are full to bursting. Your phone goes off and you're holding a plate of peas which are soggy and they're going all over your new carpet. The baby starts screaming and there's suddenly a knock at the door, followed by a loud ring that tells you you need to answer that as soon as possible. A hugely stressful situation, but one that we recognise as human beings because we know that our performance can actually be very affected if we're asked to multitask more than one or two things at the same time. Now translate that juggling act to one several leagues more difficult. It's your first shift at a new hospital and you've just come back from a prolonged period of maternity leave. The phased induction that you requested, you were denied because you were told there were not enough staff to allow it. And for the same reason, you're having to cover another doctor who's absent. So that means you're covering A&E and 6 busy wards on 4 different floors. It's also February, so your team is all new and they need extra support. You're the registrar. You put your bag down to get the handover, but immediately the arrest bleep goes off, so you have to attend straight away. And while you're doing that, you might miss some key information. When you get back, you're sadly told about a very sick child on one of those busy wards you're covering that is not for resuscitation. The duty consultant has forgotten that he's on call that day, but another consultant has been asked to provide some cover. However, they do have their own workload, so you feel that you shouldn't be bothering them unless absolutely necessary. You go along to A&E and you meet a boy there and you make a provisional diagnosis of viral gastroenteritis. He doesn't look unstable. Unbeknownst to you, he's being looked after by an agency nurse who did feel under some pressure to do that shift on a busy ward and has been working 11 hours straight. You're suddenly called away to lumbar puncture a baby who may have septic meningitis. And there's a delay as you get more and more GP calls. Your beep keeps going off and you're having to review more and more patients. And that unfortunately means that you are delayed in going back to see child B. But the chest x-ray that you ordered for him, there's no alert to tell you that's back. You get back there and you see the chest x-ray. It's not been reported, but you think he's got a chest infection. And so you prescribe some antibiotics. However, there's a delay because the nursing staff on the ward are busy before they are given. The hospital blood results IT system is down that day for several hours. So you have to call for every single result. No abnormal results are given. You call up and you miss the significance of some of the findings that you're told over the telephone. The duty consultant turns up for his late afternoon ward room around 4:30 p.m. and you update him with the status of child B, who you think is slightly improving. He will later tell the hospital investigation that although he heard the results of the abnormal blood gas results, he didn't review child B because you didn't ask him to. Unbeknownst to you, the child B is moved to another ward. 30 minutes later, the arrest bleep goes off. While running to the arrest, you find yourself on the same ward you think you were told about that morning, where the sick child is who is not for resuscitation. And you tell that to the arrest team present in the room. But it's not. It's child B. There is a brief delay before your mistake is realised and resuscitation is restarted. Sadly, Despite all efforts, the child tragically dies. But it is subsequently agreed that your mistake would not have made any difference to the outcome. However, at all subsequent investigations, it's mainly you and the agency group nurse who are blamed for his death, despite the huge number of hospital systems failings. What's more, the police have come to the door, and you find yourself at the centre of a criminal investigation. This is not fiction. This is what happened in the tragic case of Jane Adcock in 2011. Jack absolutely should have received better care. But only 2 clinical staff were criminally convicted: Dr. Hadiza Bauer-Garber and nurse Isabella Morrow. When I was growing up, I was known, from about the age of 9, I was known as the kid that you take your injured animals to, your vulnerable animals who are damaged, not thought to survive. And she would try to put them right, not always successful. So, tortoises that wouldn't eat, pigeons unable to fly, I would try to put them right. But I didn't want to be the patron saint of lost causes. Decades later, I still hold a mental snapshot of the warm, cloudless day when my pigeon swooped up to the top of the bingo hall in Weston-super-Mare. It had spent 6 weeks pooping all over my bedroom. However, my pigeon and I proved everyone wrong because it was a bruised wing, not a broken one. In my adult life, that calling became much more serious. I found myself drawn towards vulnerable colleagues who were in some kind of trouble. Some of them were employed by healthcare organisations who seemed to care more for themselves than it did for them. Let's talk about the case of David Selou. David was my colleague at Ealing Hospital until 2012. He was the go-to surgeon, the man that you called if you had a problem with a patient. He could fix it. He's quietly spoken, diligent, conscientious and caring. And yet, in 2013, he found himself convicted of gross negligence manslaughter at the Old Bailey after the death of a patient in a local private hospital. There was a collective jaw drop at his imprisonment. Those of us who knew him absolutely saw this as unjust. And yet, his counsel, his lawyer at trial, had told him no appeal was possible. I was asked to lead the campaign to try to launch an appeal and overturn that conviction. I worked with his wonderful wife, Catherine, friends and family. It took 3 years of the hardest graft to take that appeal from scribbled, messy notes in my terribly untidy Ealing office to the Court of Appeal in central London. Despite overwhelming odds, we completely overturned the conviction. Such a thing was incredibly rare in this area of healthcare. And to this date, it is the only out-of-time appeal, because he'd lost his right to appeal, that has ever been successful in this area of healthcare. It reconnected us with the hope that if we could speak the truth, come together, we could overcome impossible odds. Let's go back to Hadiza. Hadiza called me shortly after her conviction. And I was astonished and shocked at the injustice of her and Isabella Naro, the nurse, being solely blamed for what happened. The hospital management conducted a serious incident review which identified 6 root causes, made 23 recommendations and 79 action points. It was very thorough and serious. But hear this, the jury did not see that report, and yet only 2 clinical staff members had been convicted. Should they have been convicted at all against such systemic failings? Was it too hard to hold the system to account? These events acted as a lightning rod for a profession at breaking point. Trainee doctors in particular were stunned and fearful, and they were, particularly in paediatrics, considering their future careers. The General Medical Council, otherwise known as the GMC, appealed against what we all felt to be a fairer tribunal decision, was that because of her conviction, she should be suspended just for 12 months while she remediated and trained, and then to come back to work. But the GMC didn't think that that was in the interest of the public. And so they took it to the High Court, and the High Court agreed with them. She was struck off the medical register. Team Hadiza and many other organisations, including ourselves, then mobilised thousands of national and international healthcare workers just to try to overcome this. They took it to the appeal court, where they were successful in overturning her strike-off. Her licence was restored. There's something else. Hadiza is a black Muslim doctor. David is from Sierra Leone. They both trusted the process. Both were actually unfailingly honest about their own role in what happened. Yet they were both convicted of manslaughter. In the last 10 years, only black and ethnic minority healthcare workers have been convicted of this offence in healthcare. That has to stop. I've worked in the NHS for about 30 years, and I've been privileged to actually co-lead the Learn Not Blame campaign at the Doctors Association. We believe that if you have medical manslaughter, there should be an element of recklessness. Now, what do I mean by recklessness? By recklessness, I mean, and I'm going to qualify this in the UK, you drive your car down the motorway or a road deliberately on the right-hand side of the road instead of the left-hand side. In other words, you know the risk, but you run that risk regardless. That is what medical manslaughter is all about. Fixing the system and getting an open, honest culture is far better than blaming people working in overwhelmingly impossible conditions. Now we know that we must remain accountable to patients and their relatives for poor care. That is fundamentally important. We also know that there are people who have sadly and tragically lost loved ones who showed us the way here. They have transformed a tragedy into campaigning to make the NHS safer. They include James Titcombe, Martin Bromley, and Melissa Mead. They have led the way. So here's my question to you. When things go wrong, what part should we all play? Why do we all know how to report an underperforming colleague, but we seem less confident about reporting those who are surrounded by a metaphorical circle of pointing fingers? It's a simple thing: to listen to support, and to provide hope. There has to be an understanding of what happened to you and what you did could also be done by me. There is a simple power in bringing hope to people coming out of dark spaces. What do we need to do? We need to be unashamed risk takers. We need to be non-judgmental. And we need to be able to mobilise groups of people to bring hope. This absolutely has to happen. But I have to tell you that sometimes this can come at a cost. It can come at a cost to your time. It can come at a cost to your relationships. It's not right, but it can sometimes happen. And sometimes it can affect your health. Healthcare organisations must change, but our senior politicians and our leaders running our hospitals must take more responsibility when things go wrong, especially if there's been a lack of resources. People might say to you, why do you do that? Why do you do this? A lot of people said that to me. There's a simple answer to that question, isn't there? It's the right thing to do. Being a hope bringer is not a dangerous thing. It's a simple thing to help. What we need to do as a hope bringer is to keep breaking that cycle of vicious blame and shame so that our healthcare can be the best that it can be. So, please, keep telling these stories. Keep listening and supporting. Keep bringing hope